Today, my topic is present with how to prevent the complication of the PAE. So how to prevent the approach the posterior artery embolization. So we must identify the posterior artery. So then the selection to the posterior artery and deal with the intraprostatic anastomosis, and then to do about the post-embolization syndrome. So how to identify the posterior artery? We can use the imaging technique. We do the PCA and combine CT during the procedure and angiography angle if you do not do the CTA or combine. Procedure detail, you can see the posterior stent, vascular leg, or you can use the Foley. And sometimes you need the patient feel the warmness of the anus or the penis area. These are the first few cases we have to do with the Foley insertion. With the Foley, you can replace some water with your contrast, and you can see the Foley position with the dense contrast. So you see the artery beneath the Foley balloon is the target area. And if your size, the prostate size is bigger, you can see the prostate stent just like we know the HCC. And sometimes you see some patient with the recurrent hematuria, you can see the vascular leg. And angiography angle is very important because we have to see the anterior trunk opening. So most useful is the 30 degrees epistatal. But now I do with the lateral view because we have a CTA. This is the oldest patient I do. In my experience, this is a 100 years old patient. This area is a very stenosis I can do with a snap-back approach or femoral approach. I failure, but it's easy to do with the other side. So you can see the other side, my microcatheter and both posterior gland supply from the one side artery, and combined CT is also sure. Which one is the posterior artery? So this is a triangle shape, and with this is easier for me to identify this radial artery. But sometimes we have posterior gland supply with the collateral to the rectum. This is the same orange. It's a relatively round shape, but the round shape is the posterior. The triangle shape is only radial perfusion. So the combined CT is very important. You can also do the combined CT, use the iliac artery angiography with combined CT and use the combined CT to identify the posterior artery and use some software to make it easier for you. This is how I do the CTA. I show this case because it's a very exciting case. It's both side posterior artery origin from the obturator artery and both obturator artery origin from the external iliac artery. It's a very special case. And last year we have do the live case from the Mary Asia. I choose a posterior artery, which side, the right side artery, central gland PA origin from the vesical posterior trunk, and peripheral PA origin from the internal pudendal artery. And left side is a different orifice of the posterior artery from the internal pudendal artery. Only those three areas. It's a tiny me, so this one is I forgot it. And then I do the almost case from the lateral view, and you can see the CTA. But the CTA also some make a mistake. You can see we do the combined CT at the 1 area, 2 area, 3 area. That's different. In one area, the proximal area, you can see some prostate and the rectum. Both 2 and 3 branch is anterior branch, but 3 perfuse supply to the rectum. So only 2 is the target area. Now we selection to the posterior artery. I used to the guide this. So I use the pre-shaped microcatheter. Sometimes we can turn off the microcatheter because the posterior artery is very tiny, so easy to spot it. So sometimes the guide wire is easy and useful. And the guide wire may be penetrate to tiny branch over here. So I hide the guide wire with the microcatheter and just push the guide wire. It's much easier. And this I use it to treat PAE. And sometimes in different cases, the acute angle, you can use the reverse wire technique to select the disc, just like this. And I'm lucky, some cases we use the ship ninja. And you can see the ship ninja. Oh, I can turn off the controllable curve and push the guide wire. So when I meet the vesical prostate trunk, it's very useful. And sometimes, if the relatively easier is a PA from the internal pudendal artery, we can use only the microcatheter. So it's easy to do sedation to the prostate artery. And then we talk about intraprostatic anastomosis. Sometimes you do the PAE in small size prostate gland. You must to see the ipsilateral or contralateral prostate artery. You can see we do the perfect technique, and contralateral prostate artery is shown. So if you do a strong injection, there's a reflux to another target area. Non-target embolization can happen. This one is ipsilateral, and the contrast can reflux to the ipsilateral PA. So you must identify this, just like this. You can do the microcoil embolization, but not always easy. And you should be very careful. Distal area to the microcoil, because sometimes you will opening the channel over here. Just like the same, you can do the microcoil to do with the distal artery anastomosis, but it's not easy. Most cases I do with the NTG injection and before the combined CT. So I do combined CT only one time each side. And you can see after NTG injection, the anastomosis will disappear. And post-embolization is good. Also, we can do with verapamil injection. Also, we have a new product from the Occlusafe. You can see if your balloon is open here, you can prevent reflux and get the anastomosis blood flow reverse. It's very important. Or very crazy case, you can do from the anastomosis. You can do it from anastomosis first and second embolization at the PA. So you can use the microcoil, NTG, verapamil, balloon microcatheter, and directional embolization. The final is post-embolization symptom. The most complaint from the patient is dysuria, and the most severe complaint is penile ulcer. So how to reduce the dysuria? A smaller size or the regular size, the 300 to 500 micrometer. And if we will choose the smaller size, the dysuria is more happen. But similar clinical outcome. So maybe in the danger area, danger case, you can use the regular size. And in easier case, you can combine these two sizes for embolization. I usually use the prophylactic and antibiotics, and benzalkonium chloride for the symptom. And for pain relief is urogen, and diclofenac for the pain control. And most important, the intra-arterial steroid injection. I injection the steroid from the catheter, not the IV. So how the benefit of the snapback approach is not need to start the medication just like aspirin, and suitable for the obese patient, and outpatient procedure, and no need for the Foley insertion, and you can get a better response from your patient. When I do the snapback approach, I hide the guide wire within the needle, and I puncture from like this, and because I'm very afraid from the blood, so you can see some blood over the back door of the needle, so I just push the guide wire, so you can see the guide wire within the vessel. Thank you for your attention.